Hey everyone, this is Seniha. My assignment for today is on electromyography and train of 4. Here's a quick overview of my presentation. First part will be about electromyography. So what is it, what to expect during the test, what can EMG tell us, the pathway. I'll also briefly mention the difference between SEMGs and TEMGs, and lastly we'll talk about the EMG surgical application and data interpretation. The second part will consist of the train of 4, what it is and what it tells us pretty much. Electromyography is bioelectric signals that are recorded from muscle fibers, motor units, and whole muscles. Now this will be an easier way to remember the term. Electro meaning electrical, myo meaning muscle, and graphy meaning recording. So electrical muscle recordings. What is electromyography? The standard definition of electromyography is, quote, the recording of compound muscle action potentials, CMAPs, in response to spontaneous or electrically stimulated cranial nerve, spinal nerve, or ventral root activation, close quote. EMG is in fact one of the most useful modalities of intraoperative monitoring. Also, here's a fun fact. EMG was first utilized intraoperatively in the 1960s for the preservation of facial nerve function, especially during procedures involving vestibular neuromas. Okay, so what to expect during an EMG test? So a needle electrode is inserted in the muscle. Electrodes in this case are being used to detect, translate, and record the electrical signals in your muscles while they're active and at rest. Next, the neurologist will tell you when to contract or rest your muscle. And lastly, we see that the needle records muscle activity during rest and movement. As a result of EMG data interpretation, we can see whether muscle is active or inactive in a given task, when the muscle turns on and off, if there is a temporal relationship between the muscles of interest, if the muscle is fatigued, or if the muscle is injured or diseased. So some pathological profiles can be extracted from the EMG signature, such as MS. EMG is going to be generated by temporal and spatial summation of the postsynaptic muscle action potentials. Now, let's remember that muscle fiber responses are going to be all or none. And then the whole muscle response is going to be dependent on the number of excited muscle fibers. Now, unlike our motor evoked potential pathway, we're just going to really be looking at the part that starts at the level of the lower motor neuron, as you can see on the figure on the right. We know that the lower motor neuron connects upper motor neurons with muscle fibers. Now, the idea behind recording electromyography is that we find out what's going on in between the level of where the work is being performed and the muscles are being activated, right? So the pathway is going to consist of the motor unit, which is one motor axon, and all the muscle fibers that are attached. Motor unit action potentials, or MUAPs, are going to be the combined activity, which is the action potential, of the many muscle fibers attached to one axon. Ultimately, we see that recording of these MUAPs is going to be necessary for monitoring spontaneous EMG. Intraoperative EMG testing can involve SEMG, which is passive muscle recordings for the purposes of detecting cranial nerve or nerve root irritation, or it can involve TEMG, which is an electrical stimulation of neural elements or hardware for the purposes of assessing function. Now, in the upcoming slides, I will talk about the difference between these two. All right, so spontaneous EMG, also known as free-run EMG. With SEMG, we're not evoking a response, but rather we're recording passively, so no stimulation parameters in this case. Spontaneous EMG activity can be used to intraoperatively monitor the corresponding nerve roots responsible for muscle innervation, right? So this spontaneous motor activity can be measured with recording electrodes, which are, again, placed in the muscles of interest and based on the structures at risk. This obviously depends on the type of surgery. Spontaneous EMG is standard for spinal nerve root monitoring, which should be recorded from myotomes that are innervated by the nerve roots involved in the specific surgery, again, as I've said earlier. Now, even though no stimulation is performed, this is important, even though no stimulation is performed for this technique, surgical manipulation such as pulling, stretching, or compression of nerves produces neurotonic discharging, which results in activity in the corresponding innervated muscles. Now, on the other hand, we have triggered EMG. So TMG is a method that can be used to determine whether screws have breached the medial or inferior pedicle wall and therefore pose a risk to the exiting nerve root at that level. So when a pedicle screw is accurately placed, the surrounding bone acts as an insulator to electrical conduction, and a higher amount of electrical current is then required to stimulate the surrounding nerve root. Electrically triggered EMG, right, or TMG, also known as stimulated EMG or evoked EMG, has ultimately become a standard technique for prediction of malpositioned pedicle screws. Triggered EMG may also be recorded to direct nerve root stimulation to identify individual nerve roots and to check their integrity as well. As we already know, the application of EMG in most of our scenarios is going to be to measure the function of nerves, but if we're trying to measure the function of nerves, then why do we monitor muscles, right? Now, it's important to remember that muscle groups are innervated by nerves. So even though the recording is taken from the muscle, the purpose is to look at the innervated nerve's activity. And here we see the irritation in the nerve, which could be shown in the muscle it supplies function to. So here on the right, you see a person with a couple recording electrodes hooked up to the forearm, and then contracting those muscles results in this kind of electromyography that you see on the screen. So the EMG surgical application is that action potentials might be fired off in surgical scenarios such as vibration, electricity, pulling, poking, and etc., and can be manifested as spikes, burst trains, and neurotonic discharge. Now I'll quickly go over these. Spikes are single, biphasic, or triphasic spikes. There are these types, and they're generally caused by an instrument touching the nerve root and is usually not very concerning. Bursts are identified as transient complex EMG and must be reported immediately. These are caused by bumping into the nerve, which then results in brief mechanically induced activation of many motor units simultaneously. So yeah, again, it must be reported immediately. Spike trains are a series of multiple spikes and should also be reported immediately because they may be associated with nerve stretching, compression, or heating. And lastly, neurotonic discharge is a high-frequency compressed spike train which correlates with nerve injury and possible post-operative deficit. Additionally, baseline activity can correlate with nerve irritation from adjacent tissues and structures, and this is going to be manifested as fasciculations, fibrillations, and even neurotonic discharge as well. Now, I'm not sure if I have enough time to talk about data interpretation, but I still wanted to include it in my presentation. So this slide will be on false negative scenarios. You can feel free to look into it. And then this one right here is on false positive scenarios. There are two takeaways that I would like to mention. Obviously, there's a lot more, but I wanted to mention these two in particular. One, EMG is used to evaluate the integrity of the muscle and the innervating nerve fibers. This way, we're able to indirectly evaluate function of nerves through muscle activity. Now, that's key. Function of nerves through muscle activity. And second, we ultimately see that EMG is a valuable diagnostic tool that help neurologists locate and determine the causes of diseases and these diseases which might affect your muscles and assess how much damage there is. So it's very crucial. All right, we are officially at the second part of this presentation, I promise it's not as long as the first part. Okay, so because the monitoring of motor evoked potentials and electromyography requires an intact neuromuscular junction that's not inhibited by any muscle relaxant or neuromuscular blockade, there is also a specific modality that is used to monitor the amount of blockade that's present within the neuromuscular junction. Now, this is called the train of four. The train of four consists of stimulation to a peripheral nerve to evaluate the level of neuromuscular blocking agents. So we stimulate the nerve peripherally and then record from the closest muscle that is innervated by that nerve. This way, we're able to directly assess the neuromuscular junction that's taking out any other factors such as cortical neurons, spinal cord dysfunction, or even peripheral nerve disease above that level. So in IONM, usually one of the nerves used for somatosensory evoked potentials is utilized, and that's because we're already stimulating one of those nerves, such as the ulnar nerve or the posterior tibial nerve that are most commonly used. Anesthesiologists will use a visual inspection and look for twitches with stimulation of a peripheral nerve. Now, it's important to monitor TOF, train of four, because patients all respond to drugs differently, right? And there's a lot of variability in the duration in which they last. It's important for us to be able to assess this in real time and know if we need to give a reversal agent to be able to get a monitorable signal at critical points during the surgery, because the therapeutic window is so narrow. We need to know in real time if the information that we're getting is accurate. Now, at around 60 to 75% of the receptors being occupied, we're able to detect a block. At about 90 to 95 receptor occupancy, paralysis is complete, and adequate relaxation corresponds to a narrow range of 85 to 90% receptor occupancy. So it's important for us to monitor this throughout the cases. Right, that's a wrap. I'll go ahead and end this presentation with two questions. One, which type of SEMG activity correlates with nerve injury and postoperative deficits? A, spike activity, B, bursts, C, trains, D, neurotonic discharges. Number two, match the number of train of four with the percentage of paralyzed muscles. So we have 75 to 80%, 85%, 100%, and 95%. So go ahead and match those through letters A to D. So 0 out of 4, 1 out of 4, 2 out of 4, and 3 out of 4. Here are the answers to the questions. Number one, the answer would be D, neurotonic discharges. So this is the one which correlates with nerve injury and postoperative deficits. And number two was to match the number of train of four with the percentage of paralyzed muscles. So we have 0 out of 4 being 100%, 1 out of 4 95%, 2 out of 4 85%, and 3 out of 4 75 to 80%. Here are the references that I used. Of course, I used my notes from Mapping of the Brain and IONM 1, which I'm also taking this semester, and also Dr. Jahangiri's book, Surgical Neurophysiology, along with 3 other references. Thank you, and have a great day, everyone.